Hi, this is Brian Kim, and I'm going to share with you my first experience using the Diamatrix iris speculum and my impressions on how easy it was to use and what I could have done differently and kind of the things that I've learned in using this instrument for the first time. So this is a patient with a secluded pupil. There's 360 degrees of posterior synechiae. There's a pupillary membrane as well as a white cataract. I'm making my incisions. I'm using a cannula filled with epinephrine to try to dissect the pupillary membrane off the anterior capsule. I'm using fluid as well as just mechanical separation using the cannula to just tease off that membrane off the anterior capsule. You can see that it's quite adherent, and I'm just kind of going around 360 degrees to make sure I lyse all of those adhesions very carefully. I make my triplanar corneal incision, making a vertical groove and then tunneling and then entering into the anterior chamber. I use my forceps to remove this fine pupillary membrane, which spans most of the pupillary edge. You can see it's this thick and dark fibrotic material. So now I'm going to place the Diamatrix iris speculum. They recommend using a Kugel and hook as a second instrument. I use my index finger, and I'm using a two-handed technique. I'm using my index finger to advance the device, and you can see it engages the distal portion of the iris. That first part goes under the iris, and the two sides go over the iris, and they have kind of an alternating configuration. At this point, I should have probably just come out and then used the Kugel through the main incision to hook that subincisional portion of the device. But I tried to get a little bit fancy and kind of do it this way. The issue here is it caused the device to tilt a little bit, and so you could see down and to the right, that portion of the device went underneath the iris, and that portion of the iris speculum should be over the iris. And so I'm having to use the Kugel to kind of lift that portion of the device so that it's above the iris. Again, that part should be, what I'm touching is supposed to be below, but right there, that part's supposed to be over. So I had to basically do some more manipulation to get it in the right configuration. So that's my first learning point. I probably should have just engaged the device on all sides of the iris, but left the subincisional part separately. Now I'm going to go ahead and place an air bubble and then place trypan blue. These cases are always tricky because if you have posterior synechiae and a small pupil, you don't want to put the trypan blue in first because the iris is already so small and because of the posterior synechiae, and if you put trypan blue in first, it won't paint the part of the capsule that you really need to be painted. But then if you put viscoelastic first, then it's going to be difficult to paint the anterior capsular surface. So in my experience, what the best thing to do is get the exposure first. And so you saw I first lysed the adhesions, I broke the posterior synechiae, I placed the device in, put viscoelastic. But then it's okay, after you put viscoelastic in, you could go ahead and put in an air bubble, and then you want to very carefully paint the anterior capsular surface. And you do this by gently pushing a little bit of trypan blue, and then using the flat side of the cannula, and you just massage the dye on the surface of the anterior capsule. You just kind of touch it and you push a little bit of dye, and you're just kind of rolling it almost like you're using a paint roller over the anterior capsule. So you hear people dogmatically say you can't put trypan blue in once you put viscoelastic in, and that's absolutely false. You can see from this case that you can put viscoelastic in first, but then you put a little air bubble in, and that encourages the trypan blue to be against the anterior capsule, and then you can use that sweeping motion using the blunt end of the cannula, almost like a paint roller, to paint the anterior capsule with the trypan. So you can see that the anterior capsule is painted very nicely. I'm using my forceps to puncture the central capsule. You can tell this is not an intumescent lens. I use my corneal mark as a guide to help with my centration and size of my rhexis. This is progressing fairly smoothly, and just very carefully by grabbing and going across little by little, I'm able to complete this rhexis without any trouble. Performing my capsular fornix hydrodissection, placing the cannula out to the equator and rotating it down 90 degrees, I get a nice fluid wave. decompress the bag, and then spin the lens. I'm going to go ahead and remove the surface epinuclear material and then perform my double chop maneuver. I'm getting around the lens out to the equator with the chopper and then turning the phaco tip vertically to grab the lens on the more proximal side, and I'm crushing and sandwiching the lens material between the chopper and the phaco tip without any ultrasonic energy or vacuum. I go ahead and mechanically crush with the cross chop, chopping the contralateral heminucleus, and then I'm successively breaking up these pieces using mechanical forces, crushing and then pulsing with the phaco tip to remove the lens material. And I just continue to do this very carefully and methodically, just crushing in between and then crushing again into smaller size pieces. I'm always crushing, and once I get a bite-sized piece, I'm going to go ahead and emulsify and using the ultrasonic energy and vacuum to remove the lens pieces. As the case proceeds and you're having less and less lens material in the bag, it's very, very important to make sure you protect the posterior capsule. I like to keep the chopper deep whenever I'm phacoing, just in case the posterior capsule wants to come forward. I have that chopper as a barrier to block the posterior capsule from hitting the phaco tip. And I'm just continuing the same maneuvers throughout the case. You can tell this is a white lens. It's not a terribly dense lens, but it does have some substance to it. And now that all the lens material has been evacuated from the bag, I go ahead and switch to my BSS cannula. And to keep the chamber stable, pushing BSS, I withdraw the phaco tip and replace it with the INA handpiece. And I go ahead and start to remove any remaining cortical material. As I said before, this is a post-vitrectomized eye. As soon as I went with the irrigation fluid, you can see there's significant reverse pupillary block, and the pupil just goes way back and is pushed against the capsule or bag. There wasn't much cortical material. Place some Provisc into the bag as I withdraw the INA handpiece and I inject the intraocular lens. Once I have the lens in place, I use a Cougalin hook to disengage this iris speculum on each side. And so the trick is to turn the Cougalin sideways so that you can engage the portion of the ring that's above the iris. And so that's the key. You want to turn the instrument to the side. You can just disengage each portion of the speculum very easily without any trouble. And now this part, you want to use the injector to help withdraw the device to engage the ring, and it will collapse into the injector as you pull the lever back so that the device goes in. Now, it's possible that this device can kind of rotate, and so in order to protect the cornea during this maneuver, I've used a Cougalin hook through the second instrument. As I'm using my index finger to pull that lever back, I'm just making sure that it doesn't touch the corneal endothelium, and that was fairly uneventful. And then I go ahead and go back to INA to remove the viscoelastic. You can see again that tremendous reverse pupillary block, but that's okay. You just place the INA handpiece and lift the iris, and that relieves the reverse pupillary block. I'm continuing to remove all the material out of the eye. And at the very end of the case, this is always a little bit tough. You want to hydrate your incisions, but in the process of doing so, oftentimes in these types of cases, you can actually induce more reverse pupillary block. So the key is once you've firmed up the eye, you go in with the cannula and lift up the iris edge in the area of reverse pupillary block, and that will cause the iris to come down to normal size. And you can see I've really got good physiologic pressure, but I still have a little bit of that eccentric iris. I'm going to go ahead and place the BSS cannula in one more time, and I'm going to relieve that area of pupillary block, and then I'm going to end the case. I think this was a good case for the Diamatrix iris speculum. It provides a pretty nice expansion of the pupil, and it's fairly round in the way the iris speculum works with those alternating, a portion goes above and portion goes below the pupil in this alternating fashion. Using that Cougalin in a sideways manner helps to engage the pupil edge upon insertion, and then upon disengagement, using that same Cougalin to disengage the pupillary edge, and then using the injector to help withdraw the device. And so I think this is a pretty nice instrument. I was a little concerned about the vertical height of the instrument before placing it, but after I used it, I felt pretty good about it, and I felt it was a fairly easy way to expand the pupil with minimal trauma. And I think that this is something that anyone can do. So I hope this was helpful to you, and thank you for your attention.